Tonight, while you sleep, something dangerous may be happening and you have no idea. Right now, as I record this video, thousands of people over the age of 50 are lying in their beds in the exact same position they've slept in for decades, completely unaware that that position, that single, habitual, innocent-looking sleeping posture could be silently compressing a critical artery in their neck and setting the stage for a stroke before the sun even rises. I know that sounds alarming. It should. I'm a physician with over a decade of clinical and surgical experience, and what I'm about to share with you is something the conventional medical system almost never talks about during your routine checkups. Doctors ask you about your diet. They measure your blood pressure, they check your cholesterol, but when was the last time any doctor, any specialist sat down with you and asked, how do you sleep? In what position? On which side? With how many pillows? Never. And that silence is costing lives. Here's the shocking truth that most cardiologists won't tell you outright. According to data from the American Stroke Association, approximately 795,000 people in the United States suffer a stroke every year. That's one stroke every 40 seconds. And a significant and deeply underreported percentage of those strokes happen in the early morning hours between 2 a.m. and 8 a.m., while the person is either asleep or just waking up. Researchers have long noted this morning peak, but attributed it primarily to blood pressure fluctuations and cortisol surges upon waking. What they've been far slower to study and even slower to communicate to the public is the cumulative vascular damage caused by prolonged sustained pressure on the carotid and vertebral arteries during sleep. Think about this. You spend roughly 1/3 of your entire life asleep. If you're 60 years old, that's 20 years in bed. 20 years. And if night after night, your sleeping position has been restricting blood flow to your brain, creating microcompressions in your neck arteries, increasing your blood pressure, promoting blood clotting, and reducing oxygen delivery during the most vulnerable hours, then you are not resting. You are accumulating damage. The worst part, most people who suffer a stroke report no warning signs the night before. They went to bed feeling fine. They woke up or didn't fully wake up with facial drooping, arm weakness, slurred speech. Ordinary people. People like your neighbors. People like my patients. I've seen this pattern in my clinic more times than I can count, and I made a decision. I was going to start talking about it publicly, regardless of whether it fits neatly into a 15-minute appointment slot. By the end of this video, you will understand exactly which sleeping positions are most dangerous for people over 50. Why the anatomy of the aging neck makes this risk dramatically worse with every passing decade. What specific adjustments, easy, free, no equipment required, you can make starting tonight, and what warning signs during sleep you must never ignore. Stay with me. This may be the most important health video you watch this year. Before I go any deeper into the science, let me tell you exactly who I am and why you should trust what I'm about to share with you. My name is Dr. Kelly. I'm a physician with over 10 years of clinical and surgical practice. And I've spent a significant portion of my career working with patients over the age of 50, men and women navigating the complex, often confusing, and frequently underserved landscape of cardiovascular and cerebrovascular health. I've sat with hundreds of patients in hospital rooms after strokes, during cardiac events, in the middle of hypertensive crises, and what strikes me every single time is how preventable so many of these events were. Not entirely, not always, but more often than the system wants to admit. Here's the problem with modern medicine as it relates to stroke prevention. It is overwhelmingly reactive. The system is built to respond to emergencies, not to dismantle the quiet, cumulative, daily habits that create them. A patient comes in with a TIA, a transient ischemic attack, sometimes called a mini stroke, and what happens? They receive anticoagulants. They're told to control their blood pressure. They get a statin, and they're sent home with a pamphlet. Nobody asks them how they sleep. The research, when you go looking for it, paints a much more complex picture than the standard clinical protocol acknowledges. A 2019 study published in the journal Stroke found that patients who habitually slept in certain lateral positions showed measurably different patterns of brain waste clearance, arterial pressure dynamics, and nocturnal blood pressure dipping. A 2021 analysis from the European Journal of Neurology identified sleep positioning as a statistically significant variable in a subset of cryptogenic strokes, strokes with no clearly identified cause. Cryptogenic strokes account for roughly 25 to 30% of all ischemic strokes. That's 1 in 4 stroke patients for whom conventional medicine essentially says we don't know why this happened. I believe sleep positioning is part of that answer. Now, I want to be transparent with you. I'm not claiming that sleeping position alone causes strokes. The picture is far more nuanced than that. Hypertension, atrial fibrillation, atherosclerosis, diabetes, smoking, all of these are major and well-documented risk factors. But here is the critical point that the system misses. Your sleeping position interacts with every single one of those risk factors. It can amplify them. And in a person over 50, whose arterial walls are already less elastic, whose blood is already more prone to clotting, whose neck musculature is already beginning to lose tone, the wrong sleeping position does not just cause discomfort, it creates physiological conditions that are genuinely dangerous. What frustrates me most is that this is not cutting-edge, fringe, or controversial science. The research exists, the mechanisms are well described, but it lives in academic journals, in neurology conference presentations, in the footnotes of cerebrovascular textbooks, not in the patient-facing materials handed out at your annual physical. That gap between what the science shows and what patients are actually told is exactly why I make these videos. And it is exactly why in the parts that follow, I am going to give you the specific, actionable, evidence-grounded information that your doctor may simply not have the time or the incentive to give you. The stakes are high. Stroke is the 5th leading cause of death in the United States and the #1 cause of long-term adult disability. You deserve to know everything that is within your control. Now let's go inside the body. Because to truly understand why sleeping position matters so profoundly for stroke risk, you need to understand exactly what is happening inside your neck and brain during those 8 hours of darkness. Let me start with your carotid arteries. You have 2 of them, one on each side of your neck, and they are the primary highway for oxygenated blood traveling from your heart up to your brain. At rest, each carotid artery delivers approximately 250 to 350 milliliters of blood per minute to the cerebral circulation. These are not small vessels. They are critical high-pressure conduits that your brain depends on every single second of your life. Now add to this your vertebral arteries, 2 smaller but equally essential vessels that run through channels in the bones of your cervical spine, your neck vertebrae, before joining together at the base of your skull to form the basilar artery. Together, the carotid and vertebral arteries supply 100% of the blood your brain receives. Here is where the sleeping position problem begins. When you lie on your side, particularly with your neck rotated or laterally flexed for several continuous hours, you are applying direct mechanical pressure to these vessels. Think of it like stepping on a garden hose. You don't have to step hard for the water pressure to drop. You just have to stay there long enough. In a young person with elastic pliant arterial walls, this compression is tolerated reasonably well. The vessel adjusts, the body compensates, no lasting harm is done. But in a person over 50, the arteries have undergone years of atherosclerotic change. The walls have become stiffer. The inner lining, the endothelium, has accumulated microscopic damage. In many cases, there are already plaques present, fatty fibrous deposits that partially narrow the arterial lumen. In this environment, prolonged positional compression does not merely create a temporary dip in blood flow. It can cause the plaque to crack, rupture, or shed emboli, tiny fragments that travel upstream directly into the brain, where they lodge in small vessels and trigger ischemic strokes. There is a second mechanism that is equally alarming, the glymphatic system. This is the brain's waste clearance network, a system of fluid-filled channels that surrounds the brain's blood vessels and flushes out toxic metabolic byproducts during sleep, including amyloid beta, the protein strongly associated with Alzheimer's disease. Research from the University of Rochester has shown that the glymphatic system works most efficiently in specific sleep positions. When the body's posture disrupts cerebrospinal fluid flow, which certain neck positions absolutely can do, the glymphatic system's clearance efficiency drops by as much as 20 to 25%. Night after night, this creates an accumulation of neurotoxic waste. The third mechanism is nocturnal blood pressure. In healthy individuals, blood pressure naturally dips by 10 to 20% during sleep. This dipping is essential for cardiovascular recovery. Research shows that certain sleeping positions, particularly those that increase sympathetic nervous system activation through mechanical stress, can blunt or eliminate this protective dipping, meaning the blood pressure stays elevated throughout the night, grinding against already vulnerable arterial walls. Think of your arteries like old plumbing. If the pressure never drops, the pipes never rest. And eventually something gives way. Let me tell you about Robert. Robert is 67 years old, a retired school principal from Ohio, and when he first came to see me, he described himself as someone who had never been seriously sick a day in his life. He exercised 3 times a week, he didn't smoke, his cholesterol was borderline but managed, his blood pressure hovered around 138/85, not perfect, but his previous doctor had told him it was acceptable for his age. What brought Robert to my office wasn't a dramatic event, it was a series of what he called weird mornings. He'd been waking up with episodes of mild dizziness that lasted 10 to 15 minutes. Twice, he noticed that his right hand felt slightly clumsy when he picked up his coffee mug first thing in the morning. Once for about 3 minutes, the vision in his right eye went slightly blurry. Each time the symptoms resolved completely. So he waited. He told himself it was nothing. He told himself he was tired. He waited 4 months before mentioning it to anyone and another 6 weeks before he came to see me. When I heard his history, alarm bells went off immediately. What Robert was describing were textbook transient ischemic attacks, TIAs, mini-strokes, temporary disruptions of blood flow to localized areas of his brain. The fact that his symptoms resolved didn't mean he was fine. It meant he was being warned. I ordered a Doppler ultrasound of his carotid arteries. The results were significant. His right internal carotid artery showed a 42% stenosis, a narrowing nearly halfway through with an irregular plaque surface that indicated instability. His left side was 28% stenotic. His nocturnal blood pressure monitoring, which I added to his workup, revealed that he was a non-dipper. His blood pressure barely decreased at all during sleep. He was running at nearly full arterial pressure for 24 hours a day. Then I asked him the question, "Robert, how do you sleep?" "What position?" He looked at me slightly puzzled. "On my right side, always have, since I was maybe 30 years old. It's just how I fall asleep." He had been sleeping on his right side, directly compressing his most significantly diseased carotid artery for over 35 years, every single night. I explained the mechanism to him in detail. I explained the garden hose analogy. I explained the plaque instability that prolonged pressure could accelerate. And I outlined a specific protocol to change his sleep position, support his cervical spine properly, and implement several overnight habits to protect his cerebrovascular health. Robert followed the protocol precisely. After 8 weeks, his nocturnal blood pressure monitoring showed that he had become a partial dipper. His nighttime readings were now dropping by 8 to 10%. His morning dizziness completely disappeared after week 3. His hand clumsiness was gone by week 6. At his 3-month follow-up ultrasound, his right carotid stenosis had not progressed, and his inflammatory markers, which I had also been tracking, had dropped measurably. Robert did not have a stroke, and I believe the protocol we implemented together is a significant part of the reason why. His story is not unique, it is one of many, and it is why I am here talking to you right now. Now that you understand the mechanism and now that you've heard Robert's story, I need to talk about the mistakes. Because in my clinical experience, the majority of people who become aware of sleep-related stroke risk still make critical errors that undermine their efforts. And some of these mistakes are not only ineffective, they actively make the situation worse. Mistake #1, switching to back sleeping without addressing the pillow. The most common piece of advice people find online is simply sleep on your back instead of your side. And while back sleeping or supine sleeping does reduce direct lateral compression on the carotid arteries, it introduces an entirely different problem if not done correctly. When a person over 50 lies flat on their back with a standard thick pillow, the neck is pushed into a flexed forward position, chin toward chest. This posture compresses the anterior cervical structures, increases pressure on the vertebral arteries as they travel through the cervical spine, and promotes the type of neck muscle tension that elevates sympathetic nervous system tone overnight. I've had patients who switched to back sleeping, thought they had solved the problem, and were actually experiencing worse nocturnal blood pressure elevation than before. The solution is not just the position, it's the cervical support. And most people never address this variable. Mistake #2, using a sleep tracker without measuring what actually matters. We live in the era of wearable technology. Fitbits, Apple Watches, Aura Rings. I have patients who show me their sleep reports with tremendous pride. "Look, Dr. Kelly, I got 94% sleep quality last night." And I have to gently explain, your sleep tracker is measuring movement and heart rate variability. It is not measuring carotid blood flow dynamics. It is not measuring nocturnal blood pressure dipping. It is not measuring the compression status of your neck arteries at 3 in the morning. People who rely exclusively on sleep trackers for cardiovascular peace of mind are measuring the wrong variable. This false sense of security is genuinely dangerous. The most important overnight metric for stroke risk is nocturnal blood pressure, and measuring that requires a validated home ambulatory blood pressure monitor or a clinical 24-hour ABPM study, not a wristband. Mistake #3, taking a sleeping pill to stay in one position. I have heard this from patients more than once, and it genuinely concerns me every time. The logic goes, I keep rolling into the wrong position, so I'll take a sleeping aid to sleep more deeply and stay still. This is one of the most dangerous self-interventions I encounter. Sedating medications, including over-the-counter antihistamine-based sleep aids like diphenhydramine, suppress REM sleep, blunt the body's natural overnight blood pressure regulation, increase aspiration risk, and in older adults significantly increase fall risk upon nighttime waking. They do not create consistent positional stability. They create vulnerable, pharmacologically impaired sleep. Please, and I say this as your physician, do not take a sleeping pill to solve a positional problem. Mistake #4, ignoring morning symptoms is just tiredness. Robert waited 4 months. He normalized his symptoms. He told himself he was just tired, just getting older, just not a morning person. This delay nearly cost him everything. If you experience recurring morning dizziness, transient vision changes, unusual hand or face tingling that resolves within minutes, or a brief episode of slurred speech upon waking, these are not normal aging. These are neurological warnings. They require urgent medical evaluation, not a second cup of coffee. Everything I've shared with you up to this point, the mechanism, the mistakes, Robert's story leads to this, a specific structured, evidence-informed protocol that I have developed and refined over years of clinical practice with patients over 50 at elevated stroke risk. I call it the K.N.A.P protocol. It stands for kinetic positioning, nocturnal blood pressure management, arterial support habits, and pre-sleep preparation. Let me walk you through each component in precise, actionable detail. Step 1, kinetic positioning. The goal here is to find the optimal sleep position for your specific risk profile and to use physical supports to maintain it throughout the night. For the majority of my patients with carotid artery disease or hypertension, the preferred position is left lateral semi-reclined, meaning lying on the left side with the body at a very slight incline, approximately 10 to 15 degrees, achieved with a wedge pillow under the mattress or an adjustable bed base. Why left lateral? Because the right common carotid artery is slightly more anatomically vulnerable to compression due to its shorter trajectory from the aortic arch, and because right lateral sleeping places direct pressure on the right carotid in a way that the left side does not mirror on the left. For patients with known left-sided carotid disease, I adjust this recommendation individually. The cervical pillow must be chosen specifically a memory foam cervical contour pillow, 10 to 12 centimeters in height, for side sleeping, that maintains the ear directly over the shoulder with zero lateral neck flexion. This is non-negotiable. I recommend trying the pillow during a 20-minute daytime rest first to assess cervical alignment. Step 2, nocturnal blood pressure management. Every patient in my protocol gets a 24-hour ambulatory blood pressure monitor placed for at least one baseline night. The goal is to confirm whether you are a dipper or a non-dipper. If your nighttime blood pressure does not drop by at least 10% relative to your daytime average, you have nocturnal hypertension, and your medication timing may need adjustment. Many patients take their antihypertensive medication in the morning. Research from the HYGA chronotherapy trial, one of the largest chronotherapy studies ever conducted, found that taking blood pressure medication at bedtime rather than in the morning reduced major cardiovascular events by 45% in high-risk patients. Discuss this timing adjustment with your physician. Step 3, arterial support habits. 2 evidence-based habits. First, avoid eating within 2 hours of sleep to prevent postprandial blood pressure elevation, which peaks 30 to 60 minutes after eating and can remain elevated for up to 2 hours. Second, if medically appropriate and cleared by your physician, 300 milligrams of magnesium glycinate taken 90 minutes before bed has been shown in multiple trials to promote natural vasodilation, reduce nocturnal sympathetic tone, and improve blood pressure dipping. Do not start any supplement without first consulting your doctor. Step 4, pre-sleep preparation. 15 minutes before bed, perform gentle cervical mobility exercises, slow left-right neck rotations, chin tucks, and shoulder rolls. These activate the parasympathetic system. reduce cervical muscle tension that could compress arteries during the first phase of sleep, and have been shown to reduce systolic blood pressure by 4 to 7 millimeter Hgs when performed consistently. Avoid screens for 45 minutes before sleep. Dim all lights, keep bedroom temperature between 65 and 68 degrees Fahrenheit. These are not optional comfort suggestions. They are physiological levers. One of the most common questions I receive after patients start the K.N.A.P protocol is, how long before I see results? It's a fair question, and I want to give you an honest, realistic, week-by-week picture of what to expect because managing expectations correctly is part of making this work long-term. Let me be direct with you. The first 2 weeks are often uncomfortable. Changing a sleep position you've maintained for decades is not trivial. Your body will resist. Your muscles will be sore in unfamiliar places. You may wake up having rolled back into your old position. This is normal and expected. Most people require 10 to 14 nights before the new position begins to feel natural. Some patients use a body pillow behind their back as a physical barrier to rolling. Maintain the protocol even when it's imperfect. Progress, not perfection. During these first 2 weeks, the primary physiological changes are beginning at the neuromuscular level. Your cervical musculature is being retrained. You may notice slightly reduced morning stiffness by the end of week 2, and some patients report fewer or milder morning headaches, a sign that overnight cerebral blood flow has already begun to improve. By week 3, the majority of my patients report that the new sleep position has become significantly more comfortable. The cervical pillow, once unfamiliar, now feels supportive rather than strange. This is when nocturnal blood pressure begins to show measurable changes in patients who were previously non-dippers. On average, I see a shift of 4 to 8% in nighttime BP dipping among protocol adherents at the 4-week mark. Sleep quality typically improves measurably by week 4, not because of sedation, but because the nervous system is spending fewer hours in low-grade physiological stress from positional arterial compression. Patients often describe waking feeling more rested, less groggy, with clearer morning cognition. This is where the most meaningful clinical results appear. The majority of patients with TIA history or documented carotid stenosis who adhere fully to the K.N.A.P protocol show normalization of nocturnal blood pressure dipping, reaching the 10–15% therapeutic target range, resolution of morning neurological symptoms such as transient dizziness or hand clumsiness, measurable reduction in inflammatory markers including C-reactive protein and fibrinogen, and in follow-up vascular imaging, stabilization of carotid plaque without further progression. Let me share a second story. Margaret, 72, a retired nurse from Georgia, came to me after her second TIA in 18 months. She was already on anticoagulation therapy and had a cardiologist managing her atrial fibrillation. She started the K.N.A.P protocol as an adjunct to her existing treatment. At 8 weeks, her 24-hour ABPM showed that she had converted from a non-dipper to a full dipper, a 13% nighttime reduction. Her neurologist noted at her 3-month review that her cognitive testing scores, specifically short-term memory and processing speed, had improved measurably. She has had no further TIA events in the 14 months since. A note on side effects: in the first week, some patients experience mild cervical discomfort from the new pillow and position. This resolves within 5 to 7 days in virtually all cases. If cervical pain persists beyond 2 weeks or radiates into the arms, consult your physician. This may indicate a pre-existing cervical condition that requires separate evaluation. We've covered a tremendous amount of ground together, and I want to make sure you leave this video with complete clarity. Let me give you the 5 essential things I need you to remember from everything we've discussed today. Your sleeping position directly affects carotid and vertebral artery blood flow. In adults over 50 with any degree of arterial stiffening, plaque buildup, hypertension, or prior TIA, this is not a trivial variable. It is a modifiable risk factor that you have control over, starting tonight. The most dangerous combination is right lateral sleeping, plus a standard thick pillow, plus nocturnal non-dipping blood pressure. This triple pattern is extremely common among my patients who have experienced strokes or TIAs. If this describes you, you need to address all 3 elements simultaneously, not just one. The 4 components of the K.N.A.P protocol: kinetic positioning, nocturnal blood pressure management, arterial support habits, and pre-sleep preparation work synergistically. Implementing all 4 together produces results that are measurably superior to implementing any single element alone. Morning neurological symptoms, transient dizziness, vision changes, facial or hand tingling that resolves within minutes are medical emergencies in disguise. Do not wait. Do not normalize them. Do not blame tiredness. Call your doctor that same day. This protocol is not a replacement for your existing medical care. If you are on anticoagulants, antihypertensives, or antiplatelet medications, keep taking them. Discuss the K.N.A.P protocol and particularly the medication timing adjustment with your physician before making any changes to your treatment plan. One thing, just one. Go to your bedroom tonight and look at your pillow. Measure it if you can. Is it more than 12 to 15 centimeters tall when you're lying on your side? Is it keeping your neck in neutral alignment, ear over shoulder, or is it pushing your head upward or letting it drop down? If your pillow is wrong for side sleeping, that is the first lever to fix. A cervical contour pillow with the right height for your body is the single cheapest, most immediate, and most impactful change you can make tonight. I'd also love to hear from you. If what I've shared today resonates with your experience, if you've had symptoms you've been dismissing, or if you've always wondered whether your sleep position was affecting your health, type the word aware in the comments below. Let me know you're taking this seriously. It helps me know this information is reaching the people who need it most. I'll leave you with this. You've spent your whole life working, caring for others, showing up. You deserve to wake up tomorrow and every morning after with full function, full clarity, and full vitality. Your brain is worth protecting. And now you know how to start. I'm Dr. Kelly. Thank you for watching. Take care of yourself tonight.